Now you can simply pause this video and you can try to find out what is the problem in this ECG. This ECG is very wonderful because it has so many beautiful changes. So I like to zoom in and I like to start. The first thing is we can see that the QRS complex looks very, very small in almost all the leads. So what we are talking about is low voltage. Now what is low voltage? It's very simple. In chest leads, whenever the QRS length or the R length is less than 10 millimeter, we call it as low voltage. Now we can see this is V1 to V6, these are all chest leads, and the largest appears in V3. In V3 also, even if we see the S wave, it is hardly 5 and 7 millimeter. So this the maximum QRS or maximum R wave that we can see is hardly 7 to 8 millimeter, and we call it as low voltage if it is less than 5 millimeter. So it is less than 5 millimeter in limb leads and less than 10 millimeter height in chest leads, and in limb leads also it is hardly touching 5. It is hardly touching 5. So it is almost touching 5, but it is not more than 5 millimeters. So this is a very, very typical of low voltage ECG. Now where do we get low voltage ECG is position. It's very simple. These leads are picked up, these currents are picked up from the skin. So the heart is there underlying, and there are all the other layers, or that lungs are here, then the bones is here, bones are there, then the fat is there, then the subcutaneous tissue and the skin is there, and we place leads here. So these are the leads which we place, and there is underlying heart which is here. So more is the distance between the heart and the lead, lesser will be the voltage. So when we can get that, if there is so much of fat, if the patient is very, very obese, automatically there will be much of a fat placed here. So automatically it can be a low voltage. If the patient has emphysema, so the lungs will be so much inflated so that it will automatically create more air or more space between heart and the skin. So automatically the voltage will be less. So there will be low voltage. If the patient has huge pericardial effusion, so automatically heart is here on all the pericardial effusion is here. So it can definitely put heart at a far distance from the skin, so there can be low voltage. Same is with the pleural effusion. So with the pleural effusion also the same thing can happen. Or if the patient has significantly reduced myocardial contractility, if the patient has very, very low EF like 10% or 20%, automatically there is significantly lost myocardium. This QRS length or QRS tallness is all because of the contractility of the heart. So if heart muscle is damaged, automatically the tallness of the R wave will be gone. So even in heart failure with reduced ejection fraction, especially if the EF is 10%, 20%, automatically you can get the low voltage ECG. So this was the first thing which we can very, very nicely make out in this ECG, that the patient has low voltage ECG. Second thing which I want to focus in this ECG is we always have to see the typical R wave progression. I have told this thing again many other times, that in V1 and V2 leads, which are chest leads, there should be S wave dominance. Means R wave will be very minimum in height and S will be maximum in height. Here it is same, that V1 and V2, R wave is not there and S wave is prominent. It's perfectly fine. In V3 and V4, it should be an equalization phase. Equalization phase means R wave should be at least up to S wave, or R wave can be slightly more than S wave. And in V5 and V6, there should be only very, very tall R wave, and the R should be minimum, or R is usually not present. This is called a normal progression of R wave, which signifies usually that there is myocardium is normal, or myocardial muscle presence is almost normal, which may not be true always. And what about this ECG? In this ECG, what we can see, V1 in VT is okay, but in V3 also there is no R wave. R wave is very, very small than S. R wave is not at all there. In V4, R wave is not there at all. It is only S wave. In V5, R wave is there, but it's very small. So in V1, V2, V3, V4, R is not at all there, and there is only presence of S wave. What it may signify is we know that R wave is all because of contractility of the myocardium. So if myocardium is not there, or if the significantly myocardium is damaged, automatically it will give us a very small R wave. Now this V1 to V4 signifies all anterior wall. So it may mean that patient had earlier significant myocardial damage. Maybe patient had extensive anterior wall MI, which has reduced the myocardial contractility. That is the reason why R wave is not at all there. So usually such ECGs always may have EF of around 30 or 35%. So there may be significantly damaged myocardium. In this particular patient, the EF was around 35%. So there was damage to almost 25 to 30% of this myocardium. We have to remember this. And third thing which I want to tell is axis. We should always think of axis deviation. I'll be telling in very short. There is a very beautiful mnemonic to remember whether there is left axis deviation or right axis deviation. The mnemonic is very simple. It is RR or LL. That is, there is, if it is right axis deviation, then usually the lead 1 and 2, 3 AVF, these three means you have to place lead 1 above and you have to place all these three leads below. So if they are reaching each other, if these two leads are reaching each other, we say it is right axis deviation. And if they are leaving each other, if L stands for if they are leaving each other, going apart from each other, we call it as it is left axis deviation. So what about this? In here, the lead, we see this lead 1, it is going up, the R wave is going up, so it is going up, and lead 2 is going down, lead 3 it is going down because it is SV is going down, and lead AB is also going down. So everyone in short is going down. So they are leaving each other. So this is going up, this is going down. So they are leaving each other. So this is typical left axis deviation. How could it be right axis deviation? Very simple. Suppose if this patient had lead 1 which was negative, which was S dominant, and lead 2 going up, or lead 3 going up, or lead AVF going up, then we would say these are reaching each other. So this is right axis deviation. So RR and LL. You can also go by scientific way. For scientific way, it's very simple to understand. It's very simple to actually calculate the axis. For that, you must know that this is x-axis, this is y-axis, and in our body the heart is present here, left side. We always say that heart is present in this direction. So actually heart is placed like this. So there is some portion which is present on right, and majority of the heart portion is present on the left side. And if you see the muscle layer, this is where the major chunk of muscle is present. So major contraction flows like this. So this contracts, this contracts, this contracts, this contracts, this contracts. Every muscle contracts. So overall, if we say ki all these muscles contract, but if you want to give only and only one direction, then that will be like this. This is the vector. This is how, this is the way where the heart contracts. We must know that this is lead 1, this is lead 1, this horizontal line is lead 1, and we place here, this is lead AVL, that is left sided lead, this is AVR, this is right sided lead, and this is AVF, which is foot, this is foot lead. And where do we place the lead 2 is 60 degree to this. So this is around here, this is 60 degree, so lead 2, and 60 degree to this is lead 3. You must know this, that this is lead 1, this is AVF, this is AVL, it is at minus 30 degree here, and this is also 30 degree. So this is normal. This is normal thing that you must know. Now, when we want to calculate the axis deviation, this lead one is positive. This side is positive. This lead one is positive, and this AVF is positive. Why? Because heart is present here. The heart is present here. The current is flowing here. That is the reason why this is all positive. Now this axis, the heart is not here. The heart is in fact here. So this is negative and this is negative. So these two are, this and this are positive, and these are the two negative because heart is against this. Heart is present in this area. So these are positive. Now when we want to calculate the axis, we must know that heart is present here. So if it is heart axis comes here, we call it as left axis deviation because it is towards the left of the heart. If heart axis comes in this area, we call it as it is right axis because it is towards the right of the heart. It's very simple. It's very simple to remember. And if heart axis falls in this area, so it is neither left nor right. So we call it as indeterminate axis, which is very commonly seen in ventricular tachycardia. Now, how do you actually calculate this? Where is the heart? So for that, it's very simple. I'll erase this so that you can understand from this ECG, and you have to remember whatever I just told you. So we'll simply keep this so that we can understand. So this was AVF and this was lead 1. Now just see, we was remember this is positive, this is positive, this is negative, and this is negative. Now when we see, we have to see this lead 1. So lead 1 is this lead 1. So you have to calculate R minus S, R wave minus S. So how much is R? It is around 1, 2, 3, 4, around 4 millimeter. And how much is S? It is 0. So 4 minus 0, so it is 4. Is it positive or negative? Obviously it is positive because lead 1 is always positive. So you simply put 4 millimeter, like 1, 2, 3, and 4. So this 4 is supposed like here. And we have to calculate the AVF. Now see, what is AVF? Where is AVF? Now AVF is here. Now we have to calculate R minus S. So R is 0 and S is around 4. So R minus S is around minus 4 because R is not at all there. So minus 4. So where is minus 4? This we know is positive. So which is negative? This is negative. So we cannot place here 1, 2, 3, 4. We cannot place here because this is all positive arm. We have to place here like 1, 2, 3, 4. So this is 4. So in short, you have to intersect these two lines. So we intersect here, and whatever is the intersection point, you have to draw a line from here. So now what we get? We know that this is lead 1. We know that AVL is here at minus 30. And at around 45 to 50 we are having this axis. So this, in this particular ECG, the axis is going through this, and it is, we know this is left axis deviation. So this is how we actually calculate where is the axis, whether it is positive, negative, right axis, left axis, or it is normal axis. So this was a very interesting ECG which shown low voltage, which shown poor ejection fraction, and left axis deviation. Thank you.